annual TB training, as put together by Dr. Michelle McDonald, narrated by Karen Merritt. What is TB? It's a bacterial infection which has been around since prehistoric times. They've even found it in Egyptian tombs. Currently, it infects approximately a third of the world's population. An infection that thrives when people are housed in close quarters, like jails. It is a curable infection if there is a public health infrastructure to ensure diagnosis and treatment of active cases. Transmission of TB is person to person through aerosolization of the droplet nuclei. TB germs can be spread when a contagious person coughs, sneezes, shouts, or sings. You can get TB infection if you spend a lot of time indoors with this person. TB is contracted by inhalation of aerosolized infected particles in the range of 1 to 5 micrometers. The droplet nuclei of the TB get past all of the human defense mechanisms and into the deepest reaches of the lungs, where it can do the most damage. So, how do you generate these TB droplet nuclei that cause such problems? A normal person in one cough can produce 500 droplets. The average TB patient generates 75,000 droplets per day before therapy. This fortunately drops to 25 infectious droplets per day within 2 weeks of an effective therapy. Factors affecting the transmission of TB include the characteristics of the source case, the environment, and the characteristics of the contact. The source is coughing, or you're doing a cough-inducing procedure. The duration of their symptoms, cavitary disease, that open cave in their lung actually can create more of the droplet nuclei. Whether or not their sputum smear is positive for acid-fast bacilli. This is the tuberculosis. The environment's the next risk factor that we want to look at. The length of time spent near the infected person becomes very important. If you're only in the room with them for a short period of time, or you're not around them for very often, then you probably are not going to contract TB from them. It is reassuring that even on a 5 to 6 hour domestic flight, people who become exposed are not considered contacts and are not investigated. Distance from the infected person becomes an issue. If you can sit across the room and give those heavy droplet nuclei a chance to fall, then they're not going to get to you and they're going to give you an even better chance. The last one is the amount of clean air moving through the space, or just the circulation in the room. I mean, if you found yourself for some reason with a client that you had a concern about, certainly in addition to having them cover their cough, which is the bottom line, you could open windows, you could go outside to talk to them. There was a time when the nebulizer was broken and we had to still help patients collect their sputum samples. And we'd take them outside with our extension cord and do it out there instead of in our room. That's when the ultraviolet lights were broken, so going outside did make a difference. So the contact, if they have lived in aggregate settings, jail or prison or nursing home, just being there basically puts themselves in places where TB is likely to be transmitted. So just by being there, they have a higher chance of transmission. People who come from countries where TB is less well controlled, there's a high incidence of tuberculosis. Understand that Mexico is not one of the highest incident countries in the world by any means. It's probably a moderate to moderately high risk, but it's significantly more than the U.S., and that's probably over the last 5 years or so that we've gotten to the point where over 50% of our active cases in the U.S. are in people that are born in another country, and in our community, that vast majority of foreign-born cases are foreign-born in Mexico. If the person has a history of illicit drug use or alcohol abuse, it may be related to the fact that they impact on their immunity, and that it's true not only with injectable drugs, it's true with marijuana, snorting cocaine. Those things will make you more vulnerable if you're exposed to catching the infection because of its effect on your immune system. And the healthcare worker, it's likely because we're in a medical setting where people are sick, where the coughs might be. just to go over brief contact, as I said just a couple of minutes ago, is not going to be a risky situation. It's not a hand-to-mouth or saliva-transmitted thing. So even if you have shared dishes and utensils with someone who's infected, it's not going to be a problem in an airborne infection. So then sharing towels and linens with someone that has touched or with someone who's handling food is not going to get you TB. Now, these things, sharing dishes, utensils, sharing towels and linens, and handling food, may get you some other illness, but it's not going to get you TB. Even just some common sense tends to help if you think you're in a type of situation that is causing concern for you. I mentioned opening the windows, giving the client a tissue or a mask to cover the cough so that literally those droplets are contained close to the face. Not 100%, but it does make a huge difference. Generally maintaining a healthy lifestyle, basically eating well, resting, handling your stress. Hopefully your immune system is going to function at a higher level. First, I want to talk about the difference between what we call latent and active tuberculosis. Just having tuberculosis infection, often referred to as latent disease, is when the organism is almost asleep or dormant. That person has been exposed, but they're not sick. They're not contagious, and basically what happens is that the healthy person breathes in those TB germs, and their immune system goes to work. And they can very effectively wall off the TB into a fibrous capsule that sometimes can be big enough to be seen on a chest x-ray. And the thing that is unique about TB is that they can live in a semi-dormant state, and someone can be exposed when they're 18, and then when they're 65 and they develop diabetes, bang, all of a sudden they've got active disease. But they really had the infection for many years. And that's one of the most frequent infections that we see are those kinds of reactivations. So, latent disease, the chest x-ray is normal. These people are not sick, and if you did your sputum samples, they would have negative results. Nothing would grow. They are not coughing out any germs. So this just really emphasizes a couple of these cases. There is an opportunity to take medication for people who have the latent disease. It will decrease their chances of activating the disease by a little over 90% in their lifetime. And if you don't take the preventive medicine, the general risk for someone who has latent disease is a 1 in 10 chance in their lifetime that they will develop active disease. So, the person has no symptoms and is not sick. Yes, the person is infected with TB, but they are not infectious. The person is not a case of TB, and if no preventive medicine is taken, there's a 10% lifetime chance of developing active TB if there are no other risk factors. So, active infection, which here is referred to as TB disease, basically this occurs when the immune system that has been containing the germ kind of breaks down and allows it to multiply and divide and become more active. In this situation, the person will start to feel sick. Tuberculosis at its onset, is highly insidious. Tuberculosis at its onset is highly insidious. It's going to start out with things like the appetite's a little bit off. You're losing weight. Cough is actually not one of the first symptoms, but ultimately you will develop a cough. Once a person does develop a cough, they're very likely to be contagious. TB can affect just about any part of the body, but it is most common in the lungs. And I think that just simply because that is the initial site of the infection, but it can be in the pleura, which is the lining of the lungs. It can cause meningitis, which is actually a severe infection. It can cause swollen glands. That's a fairly common form. It can affect really any part of the genital urinary system, like the uterus, testicles, or bladder. I don't know why, but it's actually one of the relatively more common places that we see TB. Bones in the joints and then disseminated, which just means that it's spread all over. In active disease, the germs are no longer sleeping or latent, but they are multiplying and dividing. At this point in time, the TB skin test, that's the PPD, isn't always positive because just the active infection itself occupies the immune system to an extent that you may not mount the red bump on your arm. Usually by the time the source case gets any kind of attention, the chest x-ray is abnormal for pulmonary disease, and if we get sputums, they're going to be positive. Some of the symptoms for active TB disease, once it gets established, and when I say feel sick, I mean feeling run down, tired, not your usual energy, feeling off, prolonged cough, and when we use the marker of 3 weeks or more, that you don't know what it's attributed to or some other cause, not the someone who coughs every spring or fall because of whatever's out there and it happens every year. Really, it's a cough of 3 or more weeks that doesn't have any other explanation, and it can be with or without blood. Certainly a cough with blood, though, raises concern for TB. Weight loss, and ultimately people do develop fevers and particularly night sweats. And I mean soaking the sheets and maybe having to change pajamas and stuff like that. Dramatic night sweats. The cough can be productive or not productive. That doesn't really give you a tip that it's more likely to be TB or not. The person will be contagious to other people until they have had those 2 weeks of medication and formally are smear negative. But as we saw in the previous slide, their infectiousness has really gone down a lot along with the 2 weeks of therapy. Some people are going to be at a higher risk than their 10% lifetime for developing the active disease from exposure. Certainly, any kind of immunocompromised and the worldwide combination of AIDS and TB is devastating, particularly in Africa, but also in the former Soviet Union. Worldwide, TB is the leading cause of death in people with AIDS. In Arizona, it's valley fever. People who have been infected have that 10% chance, so they are more likely to develop active disease, obviously, than someone who has not been exposed. Certain medical conditions, such as diabetes, is probably one of the most common ones, but there's a range of medical conditions that have the capacity to depress your immunity. That's going to include certain kinds of cancers, in addition to certain treatments for cancer. Drugs and alcohol abuse. This is meant to quantify what you already know, that it takes a baseline healthy person and expose them to TB, then their lifetime risk is generally about 10% of getting the active disease. But it's a little higher because in the first 2 years of exposure, they really have almost a 15 times above the baseline. Baseline meaning no exposure to develop it. Of course, this goes all the way up to the 170 times greater risk if you have something like AIDS. Diabetes is about 12 times the risk, so any relatively common condition can increase people's vulnerability, the immune system breaking down and allowing the disease to become active. In your work situation, if you have clients that are manifesting things I would be watching for is certainly a cough, and particularly if they've been complaining that they've had this darn cold for a month and a half. A prolonged cough is the first flag in terms of infectiousness. Even things like, oh, I've got my bronchitis again, but it's not getting better the way it ordinarily does. And if they're using their inhalers or whatever, and certainly blood raises the chance that something serious like TB or cancer may be of concern. Coughing up blood can be caused by valley fever as well. So people who have some of those risks may be of concern. So people who have some of those risks, like drug and alcohol abuse, poor nutrition is going to affect your immune system and is probably an indirect contributor to the increased risk that we see in, say, the homeless population, who may not have good regular access to food. Don't assume that a smoker's cough is normal, and you can ask about some of those symptoms that I mentioned. You can even ask, are you feeling run down? Have you lost weight recently without trying? Are you having night sweats? Ask about some of those other symptoms, and that could increase your level of concern. Just for prevention in TB in the healthcare worker, the first thing is just to be aware of it. So if you're having a coughing client, you're going to want to do something about that, and not only necessarily for TB. I mean, there's coughs and colds and the flu running around, are some of the more common things that can be transmitted that way as well. And so we should really be pushing what we call cough etiquette in all of our work sites and waiting rooms. Good ventilation and air circulation will help. And we really would like to see an actual physical barrier available to clients, even if it means just a Kleenex box that they can mechanically cover and maintain their cough, is what we would want them to be doing. On our annual screening for the low to moderate risk people, I want to say a couple of things about that. Last year was our second year, and we tried where MBI came out to the people's work sites, and I realized that not everybody got to take advantage of that, but many of us did. We're going to try to do it again. Sometime in August is not going to be our normal month. And last thing for healthcare workers is, if despite our other efforts you still unfortunately get an exposure, to certainly consider treatment while it is still in the latent. Any questions?